them on a daily basis. So we're glad that you've been able to join us. A few housekeeping items before we start our conference. Again, to remind everyone, if you could mute upon entry, we'd appreciate if you use *6 as a mechanism to mute your phone rather than your mute button so we don't hear any background music. Also, if you have a computer, if you can ensure up here at the top, as you can see with my arrow, that you have the mute button on the sound at the very top. Again, if you have any difficulties during the call, please note that Demetria will be available. Her phone number is there. And you can also type questions, technical questions, into the chat box that you see people have already been doing over here to the right. Again, the objectives for today's webinar is to discuss the importance of a national standard for ambulance equipment and the development of a recently revised joint policy statement, Equipment for Ground Ambulances. To describe the value of the joint policy statement, Equipment for Ground Ambulances for children and those providing pediatric emergency care. And to identify recent guideline changes, factors that contributed to these changes, and challenges encountered during the development. And in the end, we hope you'll be able to list 3 potential opportunities and implications resulting from the development of the Joint Policy Statement Equipment for Ground Ambulance. Again, we're very lucky to have this session to be accredited by 2 different agencies. CEMS for those that need their EMS accreditation, and those that are looking for CME, we have accreditations to the Indian Health Service for either physician or nurse credit hours. There'll be a full 1-hour credit for this webinar. Again, a disclaimer, the accreditation applies solely to the educational activity and does not imply approval or endorsement of any commercial products or services. And again, there are no commercial interests that are supporting this educational activity, and our speakers have filed a disclosure statement. Again, important to receive your continuing education evaluation and credit is that you must participate in the whole webinar. At the end of the webinar, you'll be provided a link to fill out an evaluation and obtain your continuing education credit. If you have questions after the session or have any challenges, you can email Anthony Gilchrist at the email right here.
Hi, this is Dee Dee. I just joined.
The leader has muted your line. To unmute your line, press #6.
Beth, this is Demetria. Can you press *6 to unmute yourself?
Hello? Hello?
Yes, I hear you. Beth?
Okay, and I apologize. Yes, this is Beth Edgerton again. Did you hear me introduce our speakers?
No, I'm sorry. I had pushed the mute button. I'm sorry. Go ahead.
So at what point did you mute me? Do we get the
introduction of the speakers?
Okay, great. Well, thank you. We're very lucky to have our speakers today join us for our webinar. We appreciate their background and expertise in the field. We'll be starting with Dr. Mary Fallett, who is a professor of surgery at the University of Louisville and surgeon-in-chief at COSAR Children's Hospital. She's actively involved in trauma care with the interest in pediatric and pre-hospital care, and she was the main leadership in the development of the ground ambulance equipment list. We're also joined by Mr. Aaron Reinhardt, who is the Executive Director for the Lakes Region EMS. Prior to this position, Mr. Reinhardt was the Field Service Manager for the Minnesota EMS Regulatory Board, and he'll help us understand the perspective from EMS agency. And finally, we're glad to have one of our federal partners from the Office of EMS, Mr. David Bryson, who is the EMS specialist and currently leads the National Highway Traffic Safety Administration and its effort to implement the 2000 EMS Educational Agenda, a systems approach. And he has served as a contracting officer on many related topics that are being discussed. So again, we thank you for their expertise and their time today. Dr. Fallett.
Can you hear me?
We can hear you now. Please proceed.
Okay, good. Okay, so thank you, and it's a privilege to be here by virtue of my career as a pediatric surgeon and the fact that I have been a program director for EMS for children for several years in Kentucky, and I've also been privileged to be a member of the National Committee on Trauma and at one point chaired the pre-hospital committee. I feel like I've been exposed to the topic today at hand, and I'm going to give you a little bit of the natural history of the document, as well as try to define why it's so important for us to be communicating and trying to come to consensus on something as important as ambulance equipment. And so this is a document that is attempting to standardize equipment needs of emergency ambulance services in America, which includes the United States and Canada. And a secondary goal was to emphasize the need to standardize equipment for infants and children. This is something that's come to the forefront only recently. And also byproduct of the document is to enhance quality, safety, and consistency in emergency care for all ages. Can you go to the next slide? Next slide. So the EMS for Children performance measures, it currently includes state and territory compliance with ambulance equipment for all ages of children. In 2007, when I was, again, both on the pre-hospital committee for the American College of Surgeons and a program director, I was approached by Diana Fendia about refining the list at that time, which really did not include specific requirements for pediatric equipment, to come to consensus on pediatric needs and add them to the existing list. And if you go to the next slide, you'll see the history of the current document. So in the early 1970s, the American College of Surgeons developed the very first ambulance equipment list. In 1988, the American College of Emergency Physicians developed a parallel but separate list. And in the year 2000, the two organizations elected to come together to publish a revision of the list together, and that was actually the very first time that the Board of Regents of the American College of Surgeons approved a consensus document between two organizations, which was a major step forward. In 2005, the National Association of EMS Physicians joined the effort, and you can see a pattern forming where the document was revised and updated about every 5 years. And then in 2007, again, Diana asked me if I would lead the effort to try to revise the document to incorporate pediatric interests. And when we started the project, we were pleased to work with a task force developed by EMSC that included many other organizations, and ultimately the American Academy of Pediatrics and the National Association of EMS officials, in addition to EMSC, became co-authors for the document. Next slide. And then in the final revision, the one that we're speaking about today, the Emergency Nurses Association has also joined us. There are a few organizations that are still absent from this list, and I can see that in years to come, those organizations should also be included because this is meant to be a consensus document that we can all agree on. And most of you on the phone who've worked on consensus documents know it's tough sometimes to come to agreement. We're going to speak to some of those controversies, but I think that moving towards consensus is a good thing when it comes to trying to take care of patients in the pre-hospital care arena. Next slide. And at this point, I'll turn it over to Erin. Is Erin muted?
Good afternoon. Can you hear me now?
Yes, we can. Go ahead.
Excellent. Next slide, please. Thank you very much. I wanted to just spend a couple minutes talking a little bit about the implications for this as it comes down to the ambulance providers all across the nation. And obviously these are my perspectives, but they're really shaped by the work I have a chance to do all across the nation with ambulance services, as well as the time I've been able to spend on something called NEMSAC, the National EMS Advisory Council. So as you can imagine, ambulance services all across our nation are really struggling, especially our small rural ambulance providers are struggling with many different things, one of which is certainly their limited financial resources. It's not too hard to understand that there's a myriad of equipment available to ambulance services. Which are the right ones, which are the ones that are really proven based on science, and being able to provide that resource as ambulance services are looking to really maximize the resources that they have to make those purchases that they know will make a difference. Again, it's not so hard to understand that, especially in small rural services, the medical directors have very little time to spend with their ambulance services. Often they're volunteers themselves, often in addition to being the family practice physician in the community, they're staffing the emergency room, they're engaged in their community, and to take that additional time and be able to vet every piece of equipment, the hope, the desire was to provide them a reference, a guide with equipment that had gone through that screening process already. And the ambulance service director themselves have very limited time. Many are attempting to lead these rural ambulance services in addition to having other full-time responsibilities, both in their community, in their personal lives, in their professional lives. So this document was meant to provide a resource to those ambulance services that was based on science, that would provide the greatest value for the expense. And something I'll talk about a little bit later, and I'm sure will be mentioned by other speakers as well. But imagine now within a system of care having standardized equipment to create standardized collaboration. So if my ambulance service has the same pediatric equipment as the next one down the road, as well as the small rural critical access hospital we may serve, and then the tertiary specialized center that our patients may eventually get to, imagine that opportunity to both collaborate, to standardize, to train together. So the way that we train is the way we practice, the way we practice is the way we train. Thank you. Next slide, please. So I will turn it back over to our first speaker.
Hey, it's Mary. Can you hear me, everyone?
Yes, Mary, go ahead.
Okay. So the slide up currently is the iteration that was done before the one published in 2014, and I just wanted to show you the banner for this and also to call attention to the fact that this was actually simultaneously published in 3 different journals. There are some benefits for that, and there's also a downside in that all 3 journals have different editing requirements, so it's really a tour de force to get something published simultaneously in different entities for different organizations. Next slide. Just to briefly review how the current document was formulated, there was a letter of intent sent to each organization in March 2010, and the organizations then assigned representatives for our task force. And for each of the drafts, and there were 6 different drafts for this document, there were comment periods, and there were at least 2 national comment periods, at which point the organization sent the draft documents to all of their members and asked for comments. The task force met by teleconference 4 different times. Each time I took into account all of the comments, I summarized them, we discussed them in detail, there were notes and minutes, and then there was another draft that was generated that incorporated the comments as notes and highlights so that people could see where they were incorporated. And then once we had final approval, it actually took a year for all of the organizations to approve the final document through their various boards. And so even though I had done the revision in 2009 and I was pretty confident I could take care of another revision in a year, it took 2 years because of the consensus that was needed by the organizations, because the task force did the draft, but then each organization meets separately, usually twice a year. Their board has to give final approval, which means that each board member has to review it and approve it. So then there were comments that came back to the task force that we needed to consider, and so it's really a pretty timely process ultimately. Next slide. So this is the current policy statement. You can see it's published in only 1 journal, which we thought was more practical. We chose pre-hospital emergency care, and initially, if you did not have a subscription to that journal, you could not get a copy of it, but we have tried to take care of that and also been able to post the document so that it's available on various websites for common use. Next slide. So at this point, I, as many of you know, did a compendium of changes, and this was sent out through all of the organizations, and we're going to show a copy of this on your screen. We tried to give me control over the document, but unfortunately that didn't work out too well. So Tony is going to go through the document. In it, I have highlighted some things that I think are important in terms of changes, and I'll just discuss those briefly. And then this should be available to all of you after the webinar, but you also, I think, have access to a copy that's not highlighted. So starting at the top with the highlights, the document in 2009 did not indicate that this was for ground ambulances, and we wanted to distinguish the title to differentiate from medical air transport. So this is really meant to be for ground transport. We targeted 1 journal as we discussed. We thought about making it just a living document on the web. I think there are a couple of issues with that. One is that it's hard to trace a hard copy, if you will, of what actually was in print at the time. And so the task force ultimately decided it would be valuable to have at least 1 publication as reference for the future. Going down, we discussed whether this document should be applicable to other countries, but it really is limited to the United States and Canada in terms of its frame of reference. And if you open the balloon, Tony, the note, we have discussed updating this no less than every 3 to 5 years based on scope of practice and evidence-based information, and I've taken it back to the American College of Surgeons as to whether they would like to continue being the lead for this effort because they have done it in the past, and this will be a discussion at our pre-hospital meeting at the Committee on Trauma meeting that occurs in March, but my impression is that the college would like to continue being the lead. The introduction was revised to define the scope of BLS and ALS providers using a link to the NHTSA scope of practice, which I'll discuss a little bit more in the document. We also decided to remove all proprietary names from the document, with the exception of McGill forceps and KED, which are inextricably linked with the product, but we have a disclaimer that that does not mean that, that the groups are endorsing that particular product. We also discussed if the document should have any bearing on local policies, and if you open the note, Tony, this is something else we discussed at length and felt that the language should keep strictly to equipment and refrain from dictating policies or procedures. That's really an equipment list. We decided to forego any references to numbers of items or specific percents of solutions, that this should be up to local control. And we also recognized that, see, I think, Tony, do you need to move down a little bit? Okay, we recognize that the scope of practice for some ALS services, particularly with respect to advanced airway, is changing, and so the document should be used reflecting local procedures and their local scope of practice. Now, there were several things that relate to infants that we left as optional, and this was, as many will imagine, somewhat controversial. There are those who really believe that infants, oxygen masks and nasal cannulas and self-inflating bags should be on an ambulance, but there are many other services where practicality limits the expense of carrying them, and where they really aren't used very much, and there are suitable alternatives. And so you can see there that there's many small-sized pieces of equipment that were left on the optional list, and that was done intentionally. I think it was Tennessee who asked me if we had taken into consideration the National EMS Scope of Practice model, and did our equipment list reflect what was based in the model. And so I went back to the model and I compared it to the list, and I do have a list of certain items that we have made decisions that do not reflect the scope of practice, and we'll talk about those subsequently. We did clarify use of the arterial tourniquet, and if you open the note there, this particular reference was not published. So it's after impairing arterial flow, but that particular article was not published at the time that this went to press, but this is a very good article that deals with the evidence-based pre-hospital guideline for external hemorrhage control, so I added it there. We also changed selected references to select readings, and we did not include educational courses, textbooks, things that change but are more static references, and we did that intentionally also. We also eliminated extrication equipment as we felt that this was typically carried on another vehicle and was not something that ambulances would usually carry. Going on to the next page, this table is revised guidelines. So this is discrepancies between the EMS scope of practice and ambulance equipment guidelines. So Tony, if you scroll down just a little bit. You're going to go to the table, the next table. There you go. Okay, so on the left are the minimum psychomotor skills that are dictated in the National EMS Scope of Practice model, and on the right are the things that are different in our list. So, for example, on the left, use of positive pressure ventilation devices such as manually triggered ventilators and automatic transport ventilators are felt to be in the minimal psychomotor skills of the EMT, but we felt that that should be up to local regulation, so it is not mandatory on our list. And if you just go down through them, you can just get an idea of what we looked at in terms of scope of practice and then the decision that the task force made. And if any of you have any concerns about these and would like to discuss them in the Q&A section, I'd be glad for you to write in a question. I might be able to add some additional information for you. Then going down to the next table, I'd like to call attention first to cervical collars. So on the left, you'll see the old vision version. We need to, sorry, could you go down to the next table? Tony? Could we scroll down to the next table, section 3? There we go. Okay, so at the top is cervical collars. And on the left side, you'll see what the old language was in the 2009 version, and on the right side is the new version. And if you open the footnote for adjustable cervical collars, I think you're down too far. We want section 3, specific guideline language changes by section. Well, that's okay. So he's got required advanced language changes up. Again, the old version is on the left, the new version is on the right. A significant change is that we have added cuffed endotracheal tubes, and we've also now only mandated that there's one each of each size rather than two each. And I think this is a significant change because it really helps in terms of cost control, and many of these smaller endotracheal tubes were not used very often and often expired before anyone could use them. Let's see, looks like we went back to cervical collars, sorry. So if you open the balloon there, it shows that adjustable collars are now less expensive and a better product, and since they're adjustable, EMS agencies will not have to purchase as many. So that's why we decided to do add the adjustable collars. There still are not good collars available for children who are under 2 years of age, so we were not prescriptive about stabilization for really small children. We also added access to pediatric and adult patient care protocols. So in the last version, no protocols were required, and now we have mandated that there be access to pediatric and adult protocols. And then going down to injury prevention equipment. Keep scrolling down, please. Keep scrolling down. There we go. So one of the big areas of controversy was the availability of necessary age and size appropriate restraint systems for all passengers. And our colleague, Mr. Bryson, is going to be discussing safe transport of children in emergency ground ambulances and some of the work that's being done in that arena. Okay, can we go down now to the length weight-based tape? You'll see that at the bottom. So there was also some controversy about whether the length-based resuscitation tape should be required equipment for BLS ambulances. After a lot of debate, we ultimately decided that it should be required for both BLS and ALS, although we do have a caveat that if there's an appropriate reference material that provides guidance, that would be acceptable. And this changes the language basically to require that any ambulance carrying children have something that allows them to determine sizing for an appropriate sized child. I've already alluded to the fact that we changed the language to accommodate local and regional variation for properly trained personnel to intubate. And then rescue airway devices, which is down on page 6, top of page 6. Can you go to the top of page 6? So in the old version, there were no alternate airway devices mandated for pediatrics, and in the new version, we have asked that ambulances have a backup airway system in mind. This might include the esophageal tracheal double lumen airway, a laryngeal tube, or a laryngeal mask airway, but these are now required equipment. There were several things that moved from required to optional. One of the other things that was somewhat controversial was a lower extremity traction device, femur traction device. The task force reviewed the literature and felt that there was a high degree of misuse, that femur fractures are very painful, and that at times the use of a traction device could increase that pain, and they were not found to be beneficial to pediatric patients. In addition, it was brought up that if someone had a femur fracture, the mechanism was usually such that they were stabilized on a backboard because they might have multiple injuries, and so this has become optional. And you'll see some other things, folder stretcher, bedpans became optional. The other thing that is now on the list is optional is topical hemostatic agents and bandages, and once again I've referred to the publication that is an evidence-based guideline for external hemorrhage. Going down to cricothyrotomy, a little farther down the page. Of interest, there are many pediatric advanced courses available for pre-hospital care, for doctors, for trauma surgeons, and none of them agree on the age at which a cricothyrotomy is appropriate in a pediatric patient. And so we've referred you to a publication in 2010 that does give a nice table for advanced airway options available, but we were not prescriptive about the age at which a needle cricothyrotomy should be done or could be done. Moving down a little bit, pelvic immobilization devices. This was another thing that we really had a thorough discussion about. Pelvic fractures, for the most part, are not felt to be something that a paramedic or pre-hospital care provider has a good inclination of whether one is present or not present, and a lot of time can be wasted trying to immobilize the pelvis, and it's felt that it would be better to just stabilize the patient, bring them to a hospital, and not worry with trying to use some type of pelvic immobilization device. The exception to that would be if it was an inter-facility transport where the patient was stabilized at a hospital and was going to move to an upper level of care where the pelvic fracture was recognized and there was an effort made to stabilize it, primarily because the patient was bleeding. This is another area where we made some clarification. I think that's the last part of this document. And so what I've done, again, is tried to highlight areas that were in the old document where changes were made, what those changes were, and if any of you have specific questions about any of those changes and how we arrived at the conclusions, please write in a question and we'll try to discuss that during the Q&A period. Thank you.
This is David Bryson. Thank you for the opportunity to present today, and I trust and hope that everybody can hear me okay. Next slide, please. In the past, we had the do's and don'ts document that was jointly produced by NHTSA, our partners at the HRSA, Maternal Child Health Bureau, Emergency Medical Services for Children program, and the rest of the EMS community. Something that we found in the 90s to be at least a crutch or something helpful when we tried to figure out how best to transport children in the backs of ambulances. Next slide, please. Ooh, there you go. The present, if you will, published in 2012. Hopefully everybody's familiar with the working group best practice recommendations for the safe transportation of children in emergency ground ambulances document. This project was funded by the NHTSA Occupant Protection Division, and the project was done in partnership with them, our Office of Emergency Medical Services, our friends again from Emergency Medical Services from Children, and other federal partners. Next slide, please. Much like everything we see to do, it was a collaborative effort. Already mentioned the federal partner collaboration, but critical to remind folks that this is not a NHTSA or EMSC or federal government document or requirements, but rather it's important that, as the title states, it's working group recommendations from peers in the EMS community and in the vehicle safety arena that came together and expressed their opinions based on the most current data and information at the time. The effort was done by contract with Bearing Consulting Incorporated. Next slide, please. Overall, the purpose, we had to keep focus on the emergency ambulances and the 911 calls for that matter, because we did not have the data, the expertise, or the experience of the working group or others predominantly due to some of the limited funding to get into neonatal transports and special transport situations. So it's important to note that we just tried to focus on that arena of the origination of a 911 call. Also, the working group used the best evidence that was provided at the time. This is a project that began in late 2008, got wrapped up in about early 2011, and was posted and completed in 2012. Overall, the effort here was to help get children off the laps of personnel and parents in the backs of ambulances, because data, articles, and other information we had gathered basically was letting us know that that was the problem or the situation that was happening. I would say the most important takeaway today, if you will, from my presentation is for me to stress how important it is for EMS systems to get the document out and into their hands and to sit down and use this in advance of having to respond to any calls involving the transport of children before you go out and run those calls. Local, regional, and state partners should proactively meet, get together, and develop their protocols and procedures for transporting children. You just have to know, hopefully using this document and any other resources available to you, what is the best way to transport children, be it uninjured or critically injured through the gamut for you and your system. And that ultimately is the point of the document. So thank you, and I turn it back over to the main presenter.
Thank you, David. As we kind of bring to close our formal part of the presentation and then allow time for question and answers, I just wanted to share, again, from my perspective and from the work I'm privileged to be able to do, what I see as some potential opportunities for ambulance services all across our nation. First and foremost, I see a huge opportunity to use these guidelines as potential opportunities for grants, whether that's through states' emergency medical services for children programs, through the grant programs that are available through the United States Fire Administration, such as the Assistance of Firefighter Act grant, other opportunities that may exist through foundations. Is just see an opportunity to be able to present a grant that says, here's our chance to use these science-based consensus documents to enhance the care that we're providing within local ambulance services, which really then links into the second. I see a wonderful opportunity for collaboration within care and training. So as I look at my ambulance service in Minnesota, I look at that opportunity to first connect with the ambulance services that on a regular basis we provide mutual aid and they provide mutual aid to us. Could we ensure on that day when we have a critically ill or injured child that we have the ability to have the same equipment, so as we manage that patient, our training is similar, our equipment is similar, so that that time it's just a seamless transfer of care, bringing that patient to potentially that critical access hospital, to that tertiary care facility, to that specialized children facility. Imagine that opportunity that is based on similar standards, that allows us to collaborate with each other and ultimately hits that last point, which is supportive systems of care. Rather than potentially disjointed systems, could we use these documents as really that basic foundation to bring all of the parts of pre-hospital and hospital care together around caring for these patients that, again, often we don't do very often, at least speaking for myself. This is my 25th year as a paramedic. Thankfully, we don't have lots of critically ill and injured children, but when we do, it really tests our system. It tests my personal knowledge and just looking forward to that opportunity to use this foundation to create collaboration and to create supportive care. So I will turn it back over to Dr. Fowlett to provide some closing comments as well.
So I think at this point we can do some question and discussion.
Dr. Fowler, this is Beth Edgerton. Can you hear me?
Yes.
We had a question earlier during your presentation that maybe you can expand a little bit of a question of whether these guidelines include air ambulance or what the thoughts were behind making this specifically ground transport recommendations.
Yes, I saw that question. We did not feel that these were completely applicable to transport vehicles because those are often specialized teams. And the best reference that we have in the equipment list is from the American Academy of Pediatrics section on transport medicine. Looks like that textbook was published in 2006. I know that subsequent to our document being published, there was some thought about having a task force that might address specialty transport vehicles as well, but ours is not meant to address what equipment would be carried on those vehicles. It was felt to be outside the scope of what we were trying to do.
And Erin, we also had a question if maybe you could address regarding the acceptance of these new guidelines and the new format compared to previous iterations to the field of ambulance agencies and how that affects your daily operations and the ability to ensure pediatric equipment is still available on ambulances.
Yeah, a great question. And again, just making sure I'm clear about speaking for myself and for my particular opinion, I see it as being a positive. As I look at my own ambulance service and struggle every day with reimbursement, with staffing, with response demands, with all of the things that come with providing pre-hospital care today, I could certainly see where someone might see this as burdensome. I see it the opposite. As I look to what equipment I'll carry in my ambulances, what training I'll provide to my staff, there are many different roads that I can go. There are the alphabet soup of equipment. I can turn to any medical supplier's catalog and find page after page of pre-hospital care equipment, specifically equipment for children. I see this as an opportunity when I look through that catalog or walk through that vendor floor. I can begin to find those pieces of equipment offered by probably a multitude of vendors that I know are part of a collaborative system that were suggested through a consensus-based process. So as I add those pieces of equipment to my ambulances, I can be confident that they're the right ones and that they're going to help us provide that care to pediatric patients and not worry that I might select something only to find out that it maybe is the wrong piece of equipment or the wrong size or the wrong something. So I see it very positive, and I see opportunities with, while I'm not a member of the board of directors for CAS and certainly wouldn't speak for CAS, I certainly would see the opportunity for a group such as them to look at these documents and potentially consider them as part of their accrediting process. But again, don't speak for them, but I'm fairly confident in their leadership with Sarah McEntee, Mark Meyer, Mark Postma, and other members of their board of directors to see that collaboration. As Mary mentioned as we began, continued opportunities for more voices at the table as these documents become living documents and grow and develop over time.
Great. There was also a previous discussion in the chat box regarding backboards and PD boards, and again, Dr. Fowler, I don't know if you want to address kind of the evolving literature around that and spinal care and how the equipment list will try to remain up to date with current literature. I think an issue you touched upon in your presentation, but maybe you could expand upon the question from our listener.
Sure, I actually love to address that. So at our annual trauma symposium in Kentucky last year, we had a whole hour devoted to spinal immobilization and all of the hazards of doing that. And just this week in Kentucky, we have new cervical spine evaluation and spinal immobilization evaluation protocols that are going to be employed in the field. And so just to talk a little bit about the hazards are related to pressure sores and other immobilization complications related to being on a backboard for a prolonged period of time. And these are real problems, particularly in unconscious patients. And so the first issue is who really needs to be immobilized at the scene, and the second is if you're going to have a long carry, who needs to be immobilized in the ambulance for a long period of time. And so with respect to the first question, I think the literature would speak for people who are up and mobile at the scene of a crash, who are able to vocalize, who have no neck pain, who are already moving around, but possibly have something that needs to be evaluated in an emergency department, don't necessarily have to be put on a backboard and have a cervical collar in place. And so there are guidelines that would help decide who might need to be immobilized, both spine and on a backboard. Gunshot wounds are a place where sometimes they would be immobilized, and I think there's a growing consensus that somebody who has a penetrating injury doesn't need to be immobilized. And similarly, if there's going to be a transport, I think a transport time greater than 20 minutes should make you think about whether you really want to put somebody on a backboard as opposed to just doing a log roll or a scope stretcher or some way to immobilize the patient but not to put them on a hard backboard or hard surface. And so this also does hark back to what I said at the beginning of the webinar, which is, you know, if you had just a web-based document, then you could probably go back at this point and speculate on how you could get a small group of people together and actually make a change to the document. On the other hand, I think the evidence would suggest we need to change what we do, but we won't know that those changes, how those changes will affect patient care and whether there will actually be any complications related to the changes until they've been in effect and we can study them for a period of time. And so, you know, I would guess that by the time this document is edited again, that there will be a different set of recommendations based on immobilization and including the cervical spine.
Great. And as Tony Gilchrist reminded us, we also have investments in our targeted issue grants, and Dr. Manish Shah is working on developing a few evidence-based guidelines for the pre-hospital care setting, one that looks at spinal care. So hopefully that information will be available the next time these guidelines are revised. Not that I want to mention that because all the hard work that Dr. Fallon and the members of the committee put into this document, and I think taking a very practical approach and trying to be responsive to best practices and the evidence and along with local needs is really important. Again, I want to give the audience over to Dave to see if you want to help us in that sense of managing consensus statements such as this with scope of practice and EMS agendas and how that process works and how we can improve that in the future. If you get a chance, Dave, we're not hearing you, so I don't know if you're still on mute.
Sorry about that, Dr. Edgerton. Can you hear me?
We can hear you now, yes. Thank you.
Very good. I believe you were asking something about how the education agenda and the agenda for the future might change for some of these issues. Is that correct?
Well, in the sense of, I think, correct me if I'm wrong, Dr. Felt, that this is the first time we really looked at kind of the crosswalk and integration at a really close level with the Office of EMS and just what you see in the future as that scope of practice becomes refined and how consensus documents such as this equipment list will move forward of how that collaboration worked and how we keep that intersect going in the future.
Absolutely. I think we're at an important crossroads as the original education agenda for the future in 2000 didn't really get into or lay out a plan for revision to some of its components, the National EMS core content, the scope of practice model, down to the education standards. So just recently, in December, as a matter of fact, the National EMS Advisory Council, Aaron has already mentioned his involvement with that and is the current chair of that group, provided recommendations to NHTSA and in essence the rest of the federal partners on some minimal revisions that might be done to the education agenda. Part of that obviously would be to predominantly, if there were an opportunity to on a more frequently basis, update those components, and in particular for this discussion, the scope of practice model, and then obviously down to and looking at the education standards. So we're at a very important time now where NHTSA will work with its federal partners to figure out how that can best be done and that process so that things just like this could absolutely be incorporated in as evidence as to why those changes or tweaks may need to happen. So I think we may have an opportunity here to at least have a great discussion about the process, what data and information and evidence could be used, and I suggest people get involved in that process as much as possible.
Great, thank you. We have time for maybe just one more question if anyone wants to enter anything in the chat box. As while you're thinking about that, I'm going to move ahead to our next slide that has the information for those of you that would like to get continuing education. Again, the website link is listed here on the slide. Once you go there, you will receive an evaluation, and then your continuing education will be sent to you. Again, I would really like to thank our speakers for taking their time, and even for Aaron, who is on his vacation right now, who called in to share his experiences, and Dr. Fowlett, who we know are busy with surgeries and multiple duties, just to share the background and the amazing leadership and collaboration for these guidelines, and that we really hope are available to improve care in the field. Thank you for all of you for attending. If you have other questions, feel free to email us and we'll try to respond. And again, this webinar will be archived in the future, so if you have colleagues that weren't able to attend today, they'll have access. Again, thank you very much, and thank you to the NRC for their support of this webinar. We're now to a close. Thank you.